Good morning to all. Today we are going to talk about a symptom called nyctalopia, also called night blindness. So night blindness is a symptom where patients they have difficulties seeing in places with low luminance. For example, places illuminated by candles, places with normal lighting, but a dimmerized lighting with very low luminance. So patients with nyctalopia, they often refer to us saying that late in the afternoon, they experience a hard time seeing in those types of places. So it is very important to understand as well there are many causes for nyctalopia. So when a patient comes and say that he or she is having trouble seeing in places with low lighting or with dim lighting, we have to keep in mind that causes, for example, like low vitamin A can be responsible for that. And low vitamin A can be caused by a nutrition imbalance or also very common these days. It can also be caused by a bariatric surgery. So after a patient loses a piece of his or her intestine, the absorption of vitamin A can be lowered since it is a liposoluble vitamin. And because of that, this low vitamin A will impair the visual cycle and giving this patient nyctalopia. Other very common causes for nyctalopia is a genetic eye disease called retinitis pigmentosa. Another one is choroideremia, and other more rare diseases also can cause nyctalopia. For example, A beta lipoproteinemia or gyrate atrophy. So those are causes for nyctalopia. And also we have to understand how nyctalopia works and why we have it. It is important to understand that our retina works in a dual mode. What do I want to say with that? I want to say that our retina can be adapted with intense lighting, which is called photopic vision. It can be adapted with dim light, which is called scotopic vision, or it can be in the middle with what we call mesopic vision. So for photopic vision, the photoreceptors in our retina, in our central retina called cones, are the ones that will be responsible to capture that more intense lighting. And on the other hand, if we want to capture low lighting, a dimmer lighting, it will be our rods that will be more adapted for those dim lights. And in commonly, so in rods dystrophies, like in retinitis pigmentosa, this is why those patients will refer nyctalopia. But not only in retinitis pigmentosa, other dystrophies affecting rods, for example, cone and rod dystrophies, which is similar to retinitis pigmentosa, but affecting primarily the cones and secondarily the rods. Those patients will also experience a milder nyctalopia when compared with patients with retinitis pigmentosa. So our retina works in this dual mode where we can shift between low light adaptation or high lighting adaptation. For example, if I am walking in the beach and with a very bright sun lighting, my retinas will be adapted for photopic vision, where my cones will be working almost 100%, and my rods will be not very well adapted and not working with all its capacity under sun lighting. And so let's say that I'm not walking in the beach anymore. I'm walking in the beach, and then I decide to go inside a restaurant by the beach, which has a much lower lighting. So then my retina will shift from photopic lighting adaptation to scotopic light adaptation, where my rods will start to adapt and my cones will start to low its metabolism. So this shifting has a timing which happens very, very fast if a person doesn't have any disease. But for a person with one of those causes for nyctalopia that I previously said here, those people, they will have a longer time to adapt to a lower lighting. So this is what happens. Can we measure? Can we quantify that timing? Can we say how much nyctalopia a patient has, comparing one patient that has nyctalopia with another patient that has nyctalopia as well? Yes, we can. So we have to do a test called dark adaptation. So in this test called dark adaptation, we will actually emulate this situation of a patient walking in a place with high lighting, with a strong lighting, and then entering in a place with low lighting. So the test is done like that. First, we dilate one eye. Usually we choose the right eye first, and then we do a dilation for 40 minutes. And after that, the patient is placed in the machine, where he will receive 7,000 candelas per square meters for 5 minutes, meaning emulating the sun, like if the patient was under the sun for 5 minutes and with his or her cones very well adapted to that situation. After that, after those 5 minutes, the light will turn off, and then it will start to blink either a red light or a green light, a dim red light or a dim green light. And the patient can then tell us by pushing a button that he or she is seeing that dim light. And then if the patient see that light, the next step will be to show the patient a dimmer light, and so forth. And let's say that after a while, the patient doesn't push the button anymore because that light is so dim that he or she is not seeing it anymore. And then the software just goes back and sends a little bit stronger light again. And then we give time so that the patient can adapt. By the end of 35 minutes, we will see how far in terms of dimmer lighting the patient could go. And then we will therefore quantify the dimmest light that the patient was able to see with his or her right eye. And then we proceed doing exactly the same for the left eye, dilating it for 40 minutes. And then again, doing the test for 5 minutes under bright lighting, and then 35 minutes more in dim lighting testing and quantifying the the scotopic vision. So approximately after 3 hours, we finish the test, and then we can say how much nyctalopia that patient has. So it's very important to understand one thing here. Many people think that, oh, I can do a electroretinography, full field electroretinography, and then I can assess the rod's function by doing this physiology test for the rods. Is that true? No, it's not. Why? Because our visual system for scotopic lighting, scotopic vision, it doesn't happen only in the rods. Part of it, a very important part of it, happens in the rods, but then it has to go back to our brain, and then there is a pathway for that, a pathway that is not completely elucidated yet, but then we understand that if there is some kind of impairment with some area of or some part of our visual pathway responsible for our scotopic vision that is not in the rods, we can actually have a test that will show that the patient has nyctalopia, and a test with doing an ERG with a normal result. So we cannot say that those tests they substitute each other. So they are different, and they have to be applied differently, therefore. So this is just the part 1 for nyctalopia, and after this this lecture, we will also speak about retinitis pigmentosa. We will speak about choroideremia, A-beta lipoproteinemia, and gyrate atrophy, low vitamin A due to bariatric surgery, and that's it. Thank you very much. See you next time.